Hello.
Hey, Kirsten, can you hear me?
Yeah, I can hear and see you. That's all great. Thanks so
Yeah.
much for giving today's talk. I can see your slides, so it should be quite straightforward.
Yeah,
Yes.
yeah, sounds good. Should we just, I know it's 7, but should we wait a little bit longer for a few more people?
Yes, that sounds good. I think we've got a couple of people registered, so we'll just give it a few minutes and then
Yeah,
whenever you're ready.
yeah,
Thank you.
no worries, thank you. Hey guys, for those of you just joining, just to let you know, we're just waiting a couple minutes for, in case more people arrive, but yeah. Also, Kirsten, do I need to record this or do something about recording it, or does it just automatically?
So for when we go live, I think it automatically records and then it'll save after. So don't worry.
Cool.
I think, just if everyone could fill out the feedback, that'd be really useful for us as the series adapts, and we want to make it as useful as possible for the people watching. So yeah, that's I think the only thing.
Yeah, sounds good.
Nice.
I feel like I might just start. What do you think, Kirsten? Just because I've got quite a lot of slides to get through.
That sounds good. We've got a fair few people, and then people will trickle in, hopefully.
Yep, sounds good.
Thanks.
Cool, thank you. Hi guys, I'm Rimsha. I'm one of the F1 doctors. I'm currently at Bart's and I'm on HEMONC. We've also got Kirsten in the chat. You probably heard us talking, who's kindly sort of just helping keep an eye on the chat and things like that. And she's also sort of in charge of the whole series. So welcome to the talk on oncology. It's aimed at final years, but of course, welcome if there's any younger years here too. Just a warning that I do have quite a lot of slides to get through. So probably we'll be talking quite a lot and it might be a bit didactic, but feel free to just message in the chat or tell me to slow down. And we'll go from there, really. And I also just wanted to say, sorry, so I've made the slides, but they've been checked over by my oncology reg, who's Dr. Sophia Kostic. She couldn't come to the talk today, but just a sort of shout out and thank you to her. And then, yeah, we can get started. I hope everyone can sort of see and hear me okay, but yeah, let me know if any issues, because it says that my Wi-Fi is a little bit bad, but yeah. So if we get started, so just a quick summary of everything that we'll sort of be going through today. So oncology is, so I went to UCL and oncology for us was only a 1-week placement. So sort of felt like it wasn't a huge part of the curriculum, but I think in general, it just includes a lot of general medicine, which can kind of crop up across all of your specialties. So I think it's actually super important, and especially in your OSCEs, you can get some of the oncological emergencies. So that's sort of the main thing I'm going to be talking about today. There's 6 that I'll be going through in a bit of detail. We'll then spend a bit of time speaking the commonest cancers, so things like bowel cancer, prostate, etc. We'll briefly touch on some of the sort of cancer therapies, radiotherapy, chemo, etc. And then palliative care will be the sort of the second half of this talk, with a sort of very brief touch on ethics and law, and then we'll just get some feedback at the end if that's okay. So we'll get started with an SBA. I'm going to try and create a poll, but I've never used Medal before, so let's see how it goes. But if we just talk through the question first, so we've got a 28-year-old inpatient. Haven't given you a gender, but let's just say it's male. So he's on chemotherapy. He's got a new diagnosis of acute myeloid leukemia, and he's had a severe sore throat that started this morning. So you go to examine him. He doesn't have any shortness of breath, no cough, no chest pain, or any other infective symptoms. But he has been taking paracetamol for his headaches. So you go and look at his bloods, you see that his hemoglobin's 86, his platelets are 89, and his neutrophils are 0.7. You get the nurses to check his OBS. His OBS are all stable, including his temperature. So what is the most appropriate next step in management? You've got a few different options there. While you read through them, try and make this poll. Can you guys see that? I hope so. So I'll just give you a couple seconds to fill that out and then we can go through it. Got a couple responses so far. Okay, cool. So we'll go through it. I don't think I can show you everyone's answers, but I can stop the poll. Anyway, so most of you picked B for this one, so IV antibiotics, and the rest of you were sort of torn between options D and E, so either oral antibiotics or blood cultures. And I guess the most important thing to think about in this scenario is what are we worried about in terms of diagnosis? And it's a bit of a vague question because I've told you that all of his OBS are stable, which isn't particularly helpful. But the correct answer here is blood cultures. And I'll explain why. So the main sort of diagnosis we're thinking about here is neutropenic sepsis, and we'll go through it in more detail. But essentially, you can see that in terms of his bloods, he's pancytopenic. So he's got a low hemoglobin, low platelets, low neutrophils as well. And we want neutrophils to be ideally above 1.5 to 2. So his are actually really quite low, and understandably low because he's having chemotherapy at the moment. And chemotherapy makes most people neutropenic, if not pancytopenic. Now, I think the sort of tricky thing in this scenario is that actually his temperature was stable, and we often think that we need a high temperature or a fever to diagnose neutropenic sepsis. But in reality, a lot of patients, because they're so immunosuppressed in the first place, may actually not spike a fever. And on top of that, he's been taking paracetamol for his headaches, which can mask a fever. So you'll learn that if you're ever on an oncology job or just sort of generally, you'll see that people who are on chemotherapy, doctors are often quite resistant to prescribing them paracetamol because of the fact that it can mask fevers, and then you're sort of, you're never sure whether they're actually septic or not. And the main thing, again, to talk about here is, are we going to first give him antibiotics, or are we going to first take blood cultures? And if you think about your sort of septic screen, both of these things are equally important. We want to do both, at the end of the day. But it's always important to do blood cultures before you give the IV antibiotics, because otherwise, if you've given the antibiotics, your blood cultures won't be accurate. You may not actually grow something. But the caveat to that is obviously, if for whatever reason, you can't get any blood, or they've got terrible veins, if there's a huge delay in getting blood cultures, then we just give them the IV antibiotics. And the sort of the time period for that, which we call the fever to needle time, is 1 hour. So from when they spike, or from when you think that they've got sepsis, you should get IV antibiotics in within an hour. So if you haven't got blood cultures in that sort of golden hour period, then you just give them the antibiotics. Now, a lot of you were torn between if we did give antibiotics, would they be IV or would they be oral? And what we'll go through neutropenic sepsis in a second, but the main antibiotic that we give is tazocin, also known as piperacillin tazobactam. And actually that's not available orally, it's only available IV. So if you've got an outpatient or someone comes into the GP with this presentation, you would send them to A&E to get IVs. Oral won't do it and will be insufficient. So yeah, and I don't think anyone picked, sorry, a few of you did pick A. It will be important to optimize his analgesia, but in this case, it's not the first thing you would do. And A and C would both sort of just be dangerous and inappropriate. So we'll just talk a little bit more now about neutropenic sepsis. This is sort of my bread and butter. I'm dealing with this all day long. So, and if you get an oncology job, you will be. So neutropenic sepsis is commonest in the sort of initial week to 14 days post-chemotherapy. So once you give someone chemotherapy, it then takes a little bit of time for their neutrophils to actually drop, and that's called a nadir, so the lowest point. And the diagnostic criteria is usually a temperature more than 38 and a neutrophil count of less than 0.5. It varies between centers. So some people will use 0.5, some will use 1. It's not really that important, as long if they're neutropenic, they're neutropenic. So yeah. And although it's usually commonest in the first 2 weeks of chemo, if anyone's within 6 weeks of chemo, then we should definitely be suspecting it. In terms of the pathology, so actually in the majority of cases, it's really frustrating because we never find out what their source of infection is. We do the whole septic screen, blood cultures, urine cultures, etc., but we never sort of come to a diagnosis of where their infection was. It's very, very non-specific. But in the 50% where we do find a source, it's usually the bacterial etiology or some kind of focal infection like a pneumonia or an abscess, etc. So in terms of signs and symptoms, like I said earlier, it's very non-specific. So you may not necessarily get any localizing signs. They may not have a cough or crackles on their chest and things like that. So what's really important is that you do examine them thoroughly and examine all of their systems. But of course, as with normal sepsis, not just neutropenic sepsis, you've got all of your OBS that might sort of go off and become unstable. So tachycardia, tachypnea, hypotension as well. In terms of investigations, it's no different to your normal sepsis. You want the 6 in and 6 out. You want your blood cultures before antibiotics, urine as well. Chest X-ray isn't always required, but if you're worried about a respiratory source of infection, then definitely we would get that. And when you are getting IV access, it's always important to do a VBG as well, just to check their lactate, because if it's high, then you're worried about sort of sending them to ITU earlier on. So that's that. I'm sure I don't need to go through the sepsis 6 again, but if you get neutropenic sepsis in an OSCE, then just work through it in an A to E approach, and mention all of those management steps that we've just talked about. I've discussed fever to needle time being less than 1 hour, and like I said, our main antibiotic is piperacillin tazobactam. It's a penicillin, however, so obviously just check your patient's not got an allergy. If they do, then we usually go for meropenem instead, if it's a mild allergy. But that's sort of beyond this talk. And then obviously we escalate if they still haven't gotten better. And you will see some patients who are on something called filgrastim, which is the brand name, but essentially it's GCSF, which are basically subcutaneous injections we can give to patients to boost their neutrophil count. So if you've got a patient who's on chemotherapy and is likely to become neutropenic, then we often give them these injections just to help their counts recover a little bit quicker and make their sepsis a bit better, I guess, or prevent it in the first place. And then just sort of treat your patient as a whole. They may need a whole host of other things like fluids, antiemetics, etc. Or transfusions for our pancytopenic patient. So we'll go on to another SBA. I'll make the poll again in a second. But now we've got a 64-year-old woman. She comes into ED. She's complaining of a 2-day history of shortness of breath. When you look at her face and her upper extremities are very puffy. She's got these really bad 10 out of 10 headaches that are worse in the morning. And she's also had some visual disturbances. So again, you examine her, you notice she's got distended veins on her face, her neck, and her chest. What's the most likely etiology? We've got a few options there. I'm just going to create the poll again. Should work. Fine, so let's go through it. So the majority of you have gone for answer option C, which is lung cancer, with a couple of you going for spinal cord compression, B. So well done to those of you who said lung cancer. That is the most likely etiology. I'll go through all the answer options in a second, but it's important for me to say that. So the diagnosis we're thinking of here is superior vena cava obstruction, also known as SVCO. And all of the answer options that I've listed here could potentially cause SVCO. But the key thing is to look at the wording of the question. So they've asked you for what the most likely etiology is. And in the majority of patients, it's caused by a lung cancer. And commonly, it's a small cell lung cancer. Located in the sort of right upper part of your chest. And then following on from that, the second most likely diagnosis is lymphomas. So if we just go through the answer. So like I said, small cell lung cancer is the commonest cause. Your right upper lobe is where if you've got a cancer in your right upper lobe, that's where it will become problematic, because essentially what happens is that your cancer will either cause external compression of your superior vena cava or actually infiltrate the superior vena cava, basically causing it to block off, which means that blood from your upper extremities, from your neck, your face, your arms, can't return back to the heart through the superior vena cava, and therefore you get this build-up of fluid, build-up of congestion, a lot of edema. You'll see people's veins looking very swollen all over their, or very distended all over their bodies as well. And it's very scary. We had a lady with this just last week, and they're so distressed and just so dyspneic, it can actually be really scary. So it's really important to recognize. And yeah, like I said, other cancers include lymphomas, and aortic aneurysms are a super rare cause of SVCO, although they can actually cause it in some cases, but I've never seen it. And so ignore me. So spinal cord compression or vertebral artery rupture, they wouldn't actually cause SVCO because they're not impacting the superior vena cava at all, and are more would present with more sort of neurological symptoms and weakness and things like that. So I hope that makes sense. Just message in the chat if you've got any questions. But just to talk a little bit more about SVCO, common things to remember is lymphomas and lung cancers. Some other rarer things you can get in people with sort of thyroid issues or iodine deficiency. If they've got massive goiters in their mediastinum, then that could also cause compression of your SVC and cause similar symptoms. And also very rarely, if you've got a patient with a thrombophilia or something else that's causing a big clot in their SVC, then that can also cause obstruction. The key thing to remember for your SBAs is these symptoms of facial puffiness, breathlessness, distended veins, and then we'll talk about Pemberton's sign in a second. But the other thing is, because of all of the congestion, people can get really, really bad headaches, and that might be the main thing that they come in with. And also hoarse voice with sort of Pancoast tumors and all of that. The key sort of, if you've got an SBA which talks about investigating superior vena cava obstruction, then the main thing they'll talk about is mediastinal widening seen on either a chest X-ray or a CT thorax. And the sort of thing to remember, I guess, the special test is Pemberton's test. So it's where you basically ask your patients to elevate their arms to the side of their head like that, and you'll see that it causes their face to become very red, and also worsens their shortness of breath, which isn't obviously a nice thing to do, but if it's positive, then it's a very sensitive sign of it being SVCO. Main thing with management to remember is dexamethasone. So steroids treat this very quickly. They're sort of a temporary symptomatic measure. So we give 8 milligrams BD. Important to remember that it's IV, not oral. And then if you're worried about their airway, which can often become compromised, then obviously escalate up to an anaesthetist. And like I said, dexamethasone just sort of temporarily treats the symptoms that people are getting. And if we want to treat this more definitively going forward, then the management's usually chemotherapy, radiotherapy, or stents to actually open the superior vena cava back up or treat the malignancy to prevent it causing the obstruction. Just checking the chat if we've got any questions. I can't see anything, but I don't know if that's just because you guys actually don't have any questions. So just let me know if I'm missing something. And then a bit of a break from SBA. Let's just also talk about metastatic spinal cord compression, which is probably one of the commonest oncological emergencies that you'll see. And you should suspect this in anyone who's got a known cancer and comes in with back pain. Even if it's very mild back pain, then it's something to always be worried about, because there's such a spectrum of, how much the spinal cord's compressed, how much back pain they have, etc. So main symptom is back pain, but other things can include neurological signs, so weakness, sensory disturbances in their limbs, most commonly the lower limbs. Important to always ask about bowel or bladder dysfunction. So have they been able to open their bowel and bladder? Do they feel like they're retaining? Do they still have sensation when they're opening their bowels? All those sort of cauda-equina questions as well that you always ask for. And then back pain, obviously any back pain is worrying, but we tend to get particularly worried with all the sort of red flags. So thoracic back pain in an unusual location, etc. And again, it comes up often in SBAs, but the main investigation you want if you're suspecting spinal cord compression is a full spine MRI, and it should be done in less than 24 hours. And the reason why we image the full spine is because although they may just be symptomatic at one point, actually a third of people will have METs throughout their spinal cord or in various different places. So that's that. And then the management is also dexamethasone. People tend to vary in whether they want to give it oral or IV. We kind of do a mix on the wards. It's usually a consultant or a registrar decision anyway. But remember your PPI cover with your high-dose steroids. And then the other good thing to say in OSCEs in particular is that you want to maintain spinal precautions. So you basically want to tell your patient to keep their spine flat. They shouldn't be wandering around too much. And ideally, we put them in a brace. And you maintain these spinal precautions until neurosurgery will review all of their imaging and basically tell you whether the spine's stable or unstable, and so whether they can mobilize or whether they should remain immobilized. And the two most important people to refer to in this scenario are neurosurgery and clinical oncology. So neurosurgeons will tell you whether they want to operate on the spine, very rare. And then clinical oncology will tell you whether they would like to treat it with radiotherapy, which is usually what happens to most patients. So I've got another SBA. So again, 37-year-old female. She's got a history of AML. And also, just to say, this is probably the hardest SBA of the whole talk, so don't worry if you're a bit confused. I made it a bit vague on purpose, but she's got AML. She was discharged home 3 days ago following her first cycle of chemo. She then comes into her GP. She's had a lot of nausea and diarrhea, bowels open 7 times a day already. She doesn't have any shortness of breath, no cough, no back pain, but she hasn't opened her bladder in the last 24 hours. So the GP goes and checks her discharge letter and realizes she wasn't prescribed any supportive medication before they started her chemotherapy. She's a bit tachycardic. Her blood, so you get her full blood count. That's all normal. No anemia or anything like that. Her usanes are not back yet, so a bit suspicious. CRP is normal. And what's the most likely diagnosis? I'll make a poll. Okay, that should work. Fine. So I'm just going to move on in the interests of time. But well done. The majority of you actually got the right answer, which is tumor lysis syndrome. A few of you have gone for spinal cord compression or infective gastroenteritis. Totally understandable. The gastroenteritis, she's got a lot of symptoms of it, vomiting, diarrhea. And then with the sort of spinal cord compression, I guess, she hasn't got any back pain, which is why it's unlikely to be spinal cord compression. And the nausea, the vomiting, the diarrhea wouldn't really fit with that. The key thing I was trying to get at this question is her usanes are still pending. And with tumor lysis syndrome, we'll talk about it in a second, but people's usanes basically get very deranged and they get very high levels of potassium, phosphate, urate. So we're worried about that because we haven't got that back. And then the other thing is she wasn't prescribed any supportive medication before chemotherapy. So by that, I was trying to get at allopurinol or rasburicase. So patients who are at high risk of tumor lysis syndrome, who've got cancers, and patients who are high risk are usually patients with sort of hematological malignancies or cancers that have a rapid turnover of cells. So if you're at high risk of that, then they're usually put on prophylactic allopurinol or prophylactic rasburicase to stop it from happening. And she wasn't on anything, which is why she's at high risk of TLS. basically, and that's what I was trying to get at. So yeah, key bloods to remember are raised potassium phosphate urate, low calcium. We'll talk about why. Like I said, your leukemias and lymphomas are very high risk cancers. So the other key thing to remember in this question is she's just finished her first cycle of chemo, and it's common, TLS is commonest after the first cycle of chemotherapy, when the cancer's previously not been touched before. And again, patients present with all these vague symptoms of electrolyte abnormalities, basically. So AKIs, abdominal pain, weakness, etc. And in terms of management, we'll talk about that on the next slide, actually. But yeah, she wasn't on any prophylactic meds. So tumor lysis syndrome, essentially what happens is when you've got a cancer that's being treated with chemotherapy, essentially you're destroying those cancer cells. And when you've got a cancer that has already been dividing very rapidly and you've therefore got loads of cancerous cells, when you kill them, all the intracellular contents are released very rapidly. And these contents basically include urate, potassium, phosphate. And so those shoot up in tumor lysis syndrome, and your LDH will also be raised. The weird thing is your calcium goes low, and the reason for that is when all the phosphates released from the cancer cells, that binds to loads of calcium in the body and forms sort of calcium phosphate crystals, which can also go and deposit in various places, and that then causes your calcium in the blood to appear low, but actually it's just all bound to the phosphate. Commonest in the first sort of 72 hours of starting chemo. Lymphoma is the commonest cause, and the important investigations to do are your Usenes. We want a bone profile as well to include calcium and phosphate, and an ECG in light of the possible hyperkalemia, because that would be another thing to manage. The main treatment is hydration. So we give these patients loads and loads of fluid, and it's usually sort of 6 4-hourly bags, and they just have fluid running for hours, really. And to prevent it, always important to give allopurinol or rasburicase beforehand. Obviously, treat hyperkalemia if that's an issue. And in very severe cases, if patients have got an AKI that's not improving with hydration, then they will need hemodialysis as well. And I always found at med school it just a little bit confusing about what the difference between allopurinol and rasburicase is. So I've included a quick diagram here just to show you. It's from Pulse Notes, just to show you where the two different drugs act. So allopurinol actually stops uric acid from being formed in the first place because it blocks this enzyme. Whereas rasburicase works on uric acid that's already been formed. It just prevents it from becoming more soluble in the blood and therefore, going and affecting all of your organs and whatnot. So yeah. And then the other emergency to talk about is malignant bowel obstruction. I won't go on about this for too long because we'll talk about it in our gastro talk as well. But commonest malignancies are colorectal and gynae cancers because of location, really. And also sometimes lymphomas that involve the abdomen or, the spleen or the liver, for example. Your important investigations initially is abdominal X-ray, where you'll get your distended bowel loops, and then a CT abdo as well. And then in terms of management, it's your usual bowel obstruction management. So patients nil by mouth. We insert an NG tube with the sort of usual drip and suck management. And then a lot of patients will need surgery, and that's usually just a temporary surgery to sort of treat the bowel obstruction, rather than getting rid of the whole, cancer and doing a curative operation there and then. And sometimes we can use stents. In the long term, obviously putting patients on appropriate chemo will reduce the cancer and therefore reduce the obstruction. And the key thing to remember is never give bowel stimulants, so things like senna, metoclopramide, etc., when you've got bowel obstruction, because you will just cause the bowel to perforate. Yeah. So we've got another SBA. So now we've got a 67-year-old male. He comes into A&E. He's got a 5-day history of very crampy abdominal pain. He's also got severe pain in his thighs. In addition to this, he says he's been super thirsty and he's having to empty his bladder very often. So you do some bloods, And you get the following. So his hemoglobin's okay, his white cell count's normal, a little bit of a low EGFR, or very low EGFR rather. I'll let you form your own opinions of what you think about the calcium, but potassium and sodium are normal. So what's the most appropriate management? And I'll make another poll. Cool. So let's go through it. Sorry, I'm rushing all of this. Just got quite a lot of slides to get through. But like I said, let me know if you've got any questions. So the majority of you have gone for answer option A, which is a 500 ml bag of saline, and a few others who've gone for either prednisolone or pamidronate, which is a bisphosphonate. So again, well done to all of you who put answer option A. So the main issue here is he's got a very raised calcium. So he's got hypercalcemia. His calcium's 3.1. Very common in malignancies for several different reasons that I'll talk about. But essentially, all of the answer options here are management options for hypercalcemia. The reason why A is the most correct answer is because it's essentially the first thing that we do. So when you've got hypercalcemia, we try and just treat it with giving patients lots of fluids first to dilute the hypercalcemia, essentially. So you would try fluids, and if fluids aren't working after 4 to 6 hours, then we can move on to some of these other therapies like bisphosphonates, and the next most commonest step would usually be a bisphosphonate. Or in severe cases, if you're still not managing to fix the calcium, then we'd move on to things like pred, thiazides, or furosemide as well. But the key thing here is we fluid resuscitate patients to treat the hypercalcemia. And then, yes, the other thing I remembered is, so bisphosphonates, like I said, we usually try them after fluids or alongside fluids, but they're contraindicated in patients who have renal impairment, and we can see that our EGFR here is 15. So just something to be wary of, and pharmacists are great to speak to about this kind of stuff when you're prescribing. And then, like I said, everything else is for all the other therapies we trial only if fluid hydration hasn't worked. So hypercalcemia, you don't really need to know the normal range, I don't think, but 2.2 to 2.6. I thought the sort of this thing that they teach you all the time at med school, I actually think it's really helpful to remember the symptoms. So bones, stones, groans, thrones, psychiatric overtones. So with bones, it's essentially bone pain. Stones refers to sort of kidney stones, stones in the ureters, things like that. Groans just refers to abdominal pain, or just generally sort of pain in the bones or anywhere really. And then I think thrones is the sort of polyuria, polydipsia, the almost sort of diabetic sounding symptoms. And then mood disturbances are super common as well. And the key thing to remember is with hypercalcemia, a bit like neutropenic sepsis and tumor lysis syndrome, it just presents super non-specifically. But your calcium will always, give away the answer. And on an ECG, just remember that high calcium causes a short QT interval, whereas if you've got super low calcium, then that will cause a long QT interval as well, and something to always do. And then in terms of the causes, so just generally, not specific to oncology, but just generally in medicine, the two commonest causes of hypercalcemia are either hyperparathyroidism, or malignancy. And malignancy can be either due to a cancer producing parathyroid hormone, or in cancers like myeloma, that you get sort of local breakdown of bones, which causes calcium to be released into the blood, or very rarely you can get some sort of very rare tumours that produce vitamin D, again, causing hypercalcemia. And we've talked about the management. The only thing we didn't talk about is something called calcitonin, which, if you remember, it's something that your body, your thyroid gland naturally produces in order to reduce your calcium levels. And we can give that to patients. I think it's a synthetic form of it. But the problem with it is that it works very quickly, but then it's got a very short-term effect and you'll see their calcium rise again. Whereas bisphosphonates take a few days to work and they won't work very quickly, but then once they've worked, they will maintain a very normocalcemic range. Fine. So next, SBA. Which of the following is most associated with raised levels of CA125? Put a poll in. You guys are very quick at responding, which is great. Fine. So most of you have responded, and most of you have gone for answer option C, which is ovarian cancer, and then a few of you thinking breast cancer. It's fine. So those of you who put ovarian cancer, you're right. So again, you have to look at the wording of the question. So I think it's super, super rare, but breast cancer and in some cases colorectal cancer can cause a raised CA125, but it's very rare. If you see a raised CA125, the main thing that we're worrying about is ovarian cancer and specifically epithelial ovarian cancers. So just a quick note on tumor markers. Like I said, CA125 is for ovarian malignancies, CEA, which is CAR something embryonic antigen. That's for colorectal cancer, not used to diagnose it, but just to sort of monitor cancer after treatment. The one to remember for breast cancer is CA15-3, but we don't really use tumor markers in breast cancer because they've never been proven to be sort of sensitive or specific enough. So for liver cancer, for hepatocellular carcinoma, AFP, which is alpha fetoprotein, is the one to remember. AFP is also sometimes raised in germ cell tumors and testicular cancers, so just be aware of that. And then pancreatic cancer often crops up in SBAs as well. CA19-9 is the one to remember for that. And unfortunately, you just have to learn those. There's no kind of quick way of remembering them. I've got a few slides going through some of the commonest cancers that pop up in SBAs and are good to know about. I'm not going to go through them all in detail, we've only got about 18 minutes left. But I'll just point out some key things with each of them. So with esophageal cancer, the key thing to remember is all of your risk factors, in particular Barrett's disease, and smoking. And the other thing to remember is your alarm symptoms, which can be a sign of esophageal cancer or gastric cancer. And your alarm symptoms are, it's testing me now as well, but things like anemia, loss of appetite, loss of weight, recent onset progressive symptoms is the R, I think, and then melena or hematemesis for the M. Any of those, super worried about GI malignancies. The 2-week wait pathway, so anyone who's more than 55 with dysphagia, straight 2-week wait for esophageal cancer, and OGDs are the commonest way in which we diagnose these. Moving on to lung cancer, again, look out for your risk factors, obviously smoking, but things like asbestos are important in mesotheliomas. Obviously, the symptoms are things like chronic cough, weight loss, your usual red flags. And often in SBAs, they'll ask you what the or they'll say you've got a non-smoker, 40-year-old woman who's now got lung cancer. What's the most likely sort of histological diagnosis going to be? And it's always adenocarcinomas in non-smokers. Not always, but majority of cases. And then your usual sort of lung investigations, chest X-ray, bronchoscopies, CT staging, etc. And then finally, breast cancer. So with breast cancer, I think the most important things to know is how they present and the 2-week wait pathways. So in terms of presentation, just any breast lump thickening or lumps and bumps in the axilla as well. Changes to the nipple discharge, retraction, and just any skin changes. So that typical sort of orange peel appearance that you'll hear about and see as well. And then for your 2-week waits, there's different criteria based on whether you're more than 30 or more than 50. And worth just going through at some point and learning. And then the screening program. So obviously we've got a national screening program for breast cancer. It used to be for ages 50 to 70, but they've now extended it for 49 to 73. And basically women have a 3-yearly mammogram, or are invited to one rather. And yeah. And then in terms of investigation, so you've got your triple assessment clinics. You've got, depending on their age, if they're less than 40, some people use 35 as a cutoff, they'll get an ultrasound. And because of their breast tissues, I think a little bit more dense. And so it's difficult to fully assess it on a mammogram, and an ultrasound is better in those cases. Whereas if you're more than 40, then you'll go for a mammogram. And yeah, just to be aware that treatment for breast cancer is often very specific to receptors. So you'll hear about drugs like Herceptin, which have really revolutionized the management of breast cancer. And then a few other important ones. So colorectal cancer, I think, again, the most important thing to remember is your 2-week wait criteria. Different criteria depending on whether you're 60, 50 or 40. But regardless, if anyone's presenting with signs and symptoms of GI malignancy, then you'll do a FIT test, previously known as the FOB test, which basically detects hemoglobin in the stool, and colonoscopies as well. And then just remember there are some random sort of genetic causes, things like familial adenomatous polyposis, which is FAP, and then H10PCC, which is also often called Lynch syndrome. And sometimes in SBAs, you'll see this funny organism, so Streptococcus bovis, which if people have that, then again, you should be suspicious of colorectal cancer. Not going to really talk about prostate. I think it's one of the sort of specialties, and you'll probably hear about it in your urology talk. But key thing to remember is raised PSA, malignant feeling prostate on a PR exam, and your top investigation is a multi-parametric MRI of your prostate. Liver cancers, loads of risk factors, hepatitis C or any sort of chronic hepatitis, and cirrhosis of the liver as well. And it's often with things like fatty liver or alcoholic-induced cirrhosis. Liver cancer is essentially the last step that you get in the sort of journey of liver failure. But actually, interestingly, most liver cancers are mets to the liver rather than a primary liver cancer. Primary liver cancers are actually quite rare in the sort of grand scheme of cancers. And then we've kind of talked about gastric cancer a little bit, very similar symptoms to esophageal. The sort of SBA thing to remember is these signet ring cells, which they'll talk about sort of popping up on histology. Essentially, they look a bit like a signet ring. And the reason why they look like that is, for whatever reason, the cytoplasm in the cells and the vacuole become very enlarged and basically squish the nucleus to the corner of the cell. And that's why it looks a bit like a signet ring. But yeah, you do a gastroscopy, and obviously you would eventually do a CT or an MRI to fully stage the patient as well. I think I'm going to skip over ovarian, endometrial, renal, and bladder, but this talk will be uploaded onto YouTube, so definitely worth just going through the sort of presentations and investigations in your own time. And then just moving on to cancer treatment. So I think I always found this really confusing because you just hear about a load of chemotherapies which don't really mean anything to you. But I think what's more important is just knowing about the knowing sort of basic principles behind cancer treatment. So there's three main things to think about. We give treatment either as neoadjuvant treatment, as adjuvant treatment, or treatment only. So neoadjuvant is when you give them something, so chemotherapy, before the surgery to reduce the tumor size. So that essentially makes surgery easier. You have less to resect. Adjuvant treatment is when we give them something after surgery, and it's usually to prevent that cancer from coming back. And really, once you've sort of removed the main bulk of it via surgery, you would give them chemotherapy or something to eliminate all other cancers that are kind of roaming around everywhere. And then sometimes we'll do treatment only, which is where you just do something to eliminate the tumor. So, surgically resect a breast cancer, for example. And the three main therapies for you guys to know about is chemotherapy, radiotherapy, and up in sort of, the new thing everyone talks about is immunotherapy. So with chemo, essentially we just give them medications, loads of different sort of cytotoxic drugs, which will either make the tumor smaller, get rid of it completely, or stop it from coming back. Those are the kind of three main reasons why we would use it. Interestingly, it's so obviously on the wards I mainly see IV chemo being given, but actually it does exist as oral tablets as well, which I didn't really know before starting my hemonc job, which is quite cool. And then side effects are important to know about. So pancytopenia, low hemoglobin, low platelets, low white blood cells, bad basically. And then loads of sort of other things which are good to know about, just to sort of recognize them in SBAs. Radiotherapy, loads of different ways of delivering it. And before you give someone radiotherapy, we usually have to do very sort of careful scans of their mapping scans to know how to target the radiotherapy to wherever the cancer is. There's several different types. So external beam radiotherapy is where we just sort of externally give the patient beams of radiation. Internal brachytherapy is where you can kind of install radiotherapy emitting things in the body so that you more closely target the tumor. So yeah, and then the side effects of radiotherapy are similar to chemo, but a little bit different. They're more specific to where you've actually given the radiotherapy. So if someone's got a lung cancer and they've got radiotherapy to the chest wall, then they might get a lot of sore skin on the chest or hair loss. If you've got radiotherapy given to the abdomen, then you may have nausea, vomiting, diarrhea, etc. And obviously just generally, people can be very, very fatigued. And in the long run, radiotherapy can actually lead to secondary cancers as well, which is unfortunate really, but I have seen it happen. So that's that. And then immunotherapy has really sort of revolutionized the management of mostly renal cancer and melanomas, but people have started to use it for things like GI cancers as well. So it's super exciting. And someone at med school once told me that the way to remember the side effects of immunotherapy is all the itis reactions, so colitis, thyroiditis, anything with itis on the end really can be a side effect of immunotherapy. And often patients will get these sort of flu-like symptoms, just feel a bit sort of coryzal and unwell as well. And basically with immunotherapy, we're just giving patients a load of drugs to boost their own body's natural immune system and defense system to destroy the cancer cells, which is quite cool. So yeah. And then next SBA, which of the following chemotherapies is most associated with lung fibrosis? Just going to make a poll. Fine. Great. So most of you have replied. So 60% of people have gone for bleomycin, and then there's sort of an equal spread amongst all the other answers, which is totally fair enough. I think side effects of chemotherapy are really difficult to remember. And also, I think just as sort of general advice. I think it's probably not the most important thing for you guys to remember for SBAs, but as you do questions, you'll recognize some of the important side effects to know about. And in this case, you'll now know and learn that the majority of you are right. So bleomycin is a very common cause of pulmonary fibrosis. And then I've just listed a few sort of reactions here that I think are helpful to know about. And these are the sort of main ones that I learned at med school. So for bleomycin, it's lung fibrosis, and it's a dose-related effect. So the more you give, the worse the fibrosis. With your vinblastine, vincristine, etc., peripheral neuropathy is the main thing to sort of remember. We've got a really interesting patient on the wards at the moment who's got peripheral neuropathy induced from vincristine, and actually he had it from a previous cycle of chemotherapy, has now come back for a second cycle, but it's just not gotten any better. So actually these side effects affect people for a really long time, and is definitely something to watch out for and know about. Cyclophosphamide, bladder issues, so hemorrhagic cystitis, cisplatin, often cropped up in SBAs as either a low magnesium or, again, peripheral neuropathy. And then for your cardiac issues, so cardiomyopathy, heart failure, doxorubicin is a really common cause of that, as is Herceptin, so the drug often used to treat breast cancers. So that's that. It would be really helpful if you guys could, just a quick break before we move on to palliative care. We're running a bit behind, sorry. But if you could just scan this QR code for a bit of feedback, and then you can sort of fill that out as I move on to palliative care stuff. I'll give you guys a couple seconds just to scan that in. And you do get a certificate of attendance for filling it out, which is great for your CVs. So yeah. Fine. So I'll pop this back up at the end as well in case some of you haven't managed to get it now. But yeah, I'd be super grateful for any feedback, and it's really useful for our portfolios as well. So thank you for that. I'm just going to move on to palliative care now. We're going to have to rush through this, but I did want to spend longer on oncology anyway. So palliative care. So what is palliative care? Again, you don't need to memorize this definition by any means, but it's important to just have a vague, a way of explaining it to patients, because often you will be explaining it and people are really worried about, oh, you're about to start my family member on palliative care. What does that mean? Are you giving up on them? Things like that. So it's really important just to have your own way of explaining it. And I think the key thing is that it's an approach that we use in medicine to improve the quality of life of patients as well as their families. It's usually patients who are having problems and are approaching the sort of end of life or have life-threatening illnesses. And the main aim of palliative care is to basically relieve their suffering in many different ways. So it may be relieving their pain, it may be relieving other sort of physical symptoms like secretions, and also just treating them very holistically. So looking at things like psychosocial issues, any spiritual requirements that they may need, etc. And although this is an oncology talk, just remember that it's for patients with any long-term conditions. So people with advanced CKD, heart failure, any chronic condition like MS, etc. So yeah. And then end-of-life care. I always really I used to find the term just really confusing, and I think to date it's still sort of difficult to know when you're definitely putting a patient or labeling a patient as receiving end-of-life care. But in terms of numbers, it's really anyone who's likely to die within the next 12 months. And that can, so it's quite a long time. So it could be it could be anywhere between someone who's literally has hours or days to live versus someone who has months, and you just don't know how their disease will progress with things like heart failure. So yeah, and then there's just a few different sort of scenarios where you might put someone, you might label someone as having end-of-life care over here. Cool, so this is a really important slide. So common symptoms at the end of life. It's important that you remember these 4 symptoms because you'll all be seeing patients eventually when you're in F1 who are suffering from these things. And if someone's at the end of life and is having a lot of pain, you should still ask about all of these other symptoms as well. So agitation is very common, pain, excessive secretions, and that can be sort of mainly respiratory secretions, but also things like nasal secretions, and then nausea and vomiting can be super common as well. So yeah. Then I won't read through all of this. It's a bit depressing as well. But signs and symptoms of dying is, again, super varied. But key things to know is people who are very bedbound, requiring a lot of care, people who've become very drowsy, unrousable, just sleeping pretty much all day long. Things like not eating food or fluids, not mobilizing, not swallowing any medication, and also changes in breathing towards the end of life can be, again, a massive sign of someone not doing very well. And the key thing you might hear of in sort of SBAs, or you might even see on the wards, is something called Cheyne-Stokes breathing, which is essentially where people have these periods of not breathing at all, and then suddenly they'll start to take very deep and frequent breaths, and it can be really sort of distressing to watch. So yeah, and just generally feeling very cool peripherally, mottling of their skin, etc. So to talk about pain, this is your sort of Bible of pain. So it's WHO pain ladder, and you've got the sort of 3 different steps, and really you kind of have to assess how bad your patient's pain is. So if they're in a lot of pain, it's very severe, then you might just start them on strong opioids and then work your way down. For example, in someone who's post-op. But if you've got someone who's got much milder pain, then obviously you can start with paracetamol and work your way up. But the key thing to remember is that for mild pain, we'll give paracetamol. Remember to reduce the dose if your patient's got hepatic impairment, or is less than 50 kilograms. And then we escalate up to weaker opioids, so things like codeine, dihydrocodeine. But important to remember that a lot of people don't actually metabolize codeine, so it may not work for them. So in which case you'll need to escalate on to morphine. And then obviously in patients who've got a lot of pain, we'll give them things like Oromorph, morphine, or in renal impairment, we tend to not give morphine. And if it's just mild renal impairment, then we'll give them oxycodone. But in more sort of severe cases of renal impairment, then we can consider things like fentanyl or alfentanil as well. But that will never be you prescribing it. Nausea and vomiting. So key thing to know is that we have a lot of different antiemetics, which is great because you can try a lot of different things with patients, but they all have very different mechanisms of action and are all sort of work well for different causes of nausea. So the key thing to remember is ondansetron is really good for chemo-related nausea, and all of our chemo patients are generally put on ondansetron. Cyclizine is good if someone's got vestibular causes or vertigo or ENT issues, really. But what I learned when I became an F1, don't think I really knew this as a med student, because at med school we were told to just sort of prescribe cyclizine for everyone, is that actually IV cyclizine is not very liked in young women because it can cause this sort of high feeling and can be quite addictive. So avoid IV cyclizine, but the other routes, so things like oral, are okay. And then ondansetron can sometimes cause constipation, so just to be aware of that. So metoclopramide and domperidone, they're both dopamine receptor antagonists. But the thing that differentiates them is that with metoclopramide, it does pass the blood-brain barrier. So in patients with Parkinson's disease who've already not got any dopaminergic neurons, you don't want to give them metoclopramide because you will just worsen their symptoms. And also it's prokinetic, so you don't want to give it in bowel obstruction. Whereas domperidone, again, you don't want to give it in bowel obstruction because it's prokinetic, but you can give it to people with with domperidone, you can give it to patients with Parkinson's disease because it doesn't cross the blood-brain barrier, so it won't affect their the very few dopaminergic neurons that they've got left. So yeah. That's the main thing to know. I always found this very confusing though. And then we've got another SBA. I'm wary that it's 8 o'clock, so feel free to nip off if you need to, but I'll just sort of power on. So 80-year-old woman with metastatic ovarian cancer and heart failure. She's got severe abdominal pain. She takes modified release morphine sulfate tablets. This has recently been up-titrated, so she's on 30 milligrams twice daily. You also need to prescribe her an appropriate PRN to have for any additional breakthrough pain she's having. So what are you going to prescribe? Making a poll. Cool. So most of you have gone for A, which is 10 milligrams of immediate release Oromorph. Again, I'll just explain it in the interest of time. That is the right answer. So essentially, when patients are in a lot of pain, they'll be on regular morphine, which is your modified release morphine. And then on the PRN side of the drug chart, they will also be prescribed additional Oromorph, which is immediate acting morphine, to have for if they've got any extra pain, basically. So the way we calculate this is you need to work out how much modified release morphine she's getting in a day, which is 30 milligrams BD, so that's 60 milligrams total in a day. Of her regular morphine, and then to work out how much PRN you're going to give her, it's always a sixth of that total daily dose. So it's a sixth of 60 milligrams, which is 10 milligrams of morphine. And the important thing to remember, and how they sort of trick you out in SBAs, is the way they actually administer that morphine. So we've got two answers here that had 10 milligrams of morphine. One's immediate release and one's modified release. You want to make sure that you're always giving them immediate release Oromorph for their breakthrough pain. It can also be given sort of subcut IV if you've got a patient who can't swallow, but in the majority of cases it will just be given as Oromorph, but not as a modified release form. And then just another point to remember is obviously ibuprofen wouldn't be a correct answer here, but on top of it just not being an adequate PRN, it's also contraindicated in heart failure. So just something to watch out in exams. And just remember to always calculate the total dose. So 30 milligrams BD, total of 60 milligrams. So for opioid prescribing, so remember opioids are only for very severe pain. If you've got someone who's never been on any opiates before, then we usually just start them on 2.5 or 5 milligrams 4 hourly. And then we'll monitor them on just PRNs for a few days and see how much they're actually using. And once we know that, you know, for example, your patient's having 20 milligrams of oral morphine a day, you can then convert that into a regular modified release dose. We've talked about how to work out the PRNs. And then just in terms of symptoms, just in terms of options, like I said, morphine's our go-to, but if they've got mild renal impairment, then we'll use oxycodone. And then there's a couple other options for more severe renal impairment, so fentanyl, etc. And then with opioids, your side effects, so remember things like constipation, nausea, and vomiting. If they've overdosed, they may get very drowsy, very confused. So in all of these cases, it's very important to always co-prescribe an antiemetic and a laxative as PRN. And then some doctors, although I've never really seen it, also like prescribing naloxone PRN in maybe perhaps very elderly patients that you're worried may be very sort of sensitive to these low doses of Oromorph. So just in case they get any respiratory depression, you can reverse that with naloxone as well. So this is a drawing just from my sort of med school notes about the different conversions of sort of codeine to morphine, etc. Again, I won't go through it now. I guess the main one to know is if you're going from oral morphine to subcut morphine, then you always divide by 2. But again, we'll upload these slides, so this is definitely something that's good to memorize for your exams. Fine. Bit of a longer question. I think this might be the last SBA. But again, we've got an 82-year-old man. He's got metastatic prostate cancer. The pain team have come to review him. He's had increasingly severe generalized pain. It's particularly noticeable in his back, but he's run out of all of his pain meds, so now needs a new prescription. So you go and check his previous prescription, and you find that he's been using about 5 to 6 doses of his Oromorph per day. That's been effective, but it wears off after 2 hours, so he keeps asking for more. Each of those doses, so each of those 5 to 6 doses he's having is 5 milligrams. You need to convert him to a sort of longer-acting analgesia regime. Which of the following is the most appropriate prescription? Again, I'll just do a poll. Fast SBA, guys. Cool. So we've got 9 responses. Sorry if you're still working it out. I'm just going to quickly move on in terms of time. So well done to those of you who put answer option A. So in terms of working this out, so what we need to start by doing is we've got 2 things we need to figure out. We need to figure out how much modified release morphine he's going to need. And modified release morphine is always prescribed BD, just to remember as a rule. And we also need to work out how much immediate release Oromorph he's going to need. So first we need to work out how much morphine he's currently consuming. So he's having about 5 to 6 doses of 5 milligrams. So he's having roughly 25 to 30 milligrams of Oromorph per day. So and then what I would do here is essentially you're going to have to pick whether you're giving him 25 daily or 30 daily. But because he's got increasingly severe generalized pain, sounds a little bit uncontrolled at the moment, I would go with the higher number. So I would go with the 30 milligrams. So he's having 30 milligrams already. And to give that to him as a regular prescription, to give it BD, you would just divide it in half. So 30 milligrams total is 15 milligrams modified release morphine sulfate BD. I hope that makes sense. Just pop a message in the chat if you've got any questions. But once you've worked out that he's having, that's his modified release, you then need to work out how much PRN meds you're going to give him. So remember our rule, it was 1/6 of your total daily dose. Our total daily dose here is 30 milligrams, and 1/6 of 30 milligrams is 5 milligrams. So we're going to give him 5 milligrams of Oromorph for breakthrough pain, and usually that's given 4 hourly. So that's why that's the correct answer. With answer option B, the only wrong thing about it really is that 10 milligrams, you wouldn't give any more than 1/6 of their total daily dose. What does BD stand for? Sorry, BD stands for twice daily. I don't know what the Latin abbreviation of it is, but OD is once daily, BD is twice daily, TDS is 3 times daily, and QDS is 4 times daily. Sorry, lots of abbreviations in medicine. But yep, that's that. So that's why answer option B is wrong. The fentanyl, so a 12.5 microgram patch of fentanyl is equivalent to 45 milligrams of oral morphine. Now, you don't need to remember that, but the point I'm trying to make is that that's too much morphine. We only want him to have 30 per day. That would be 45 milligrams per day. And in our 82-year-old patient, again, that could cause a lot of toxicities and you could run into trouble, basically. And then with the last option, which was tramadol, so 100 milligrams of tramadol is roughly equal to 15 mgs of morphine. And if you're giving that QDS, you'd basically be giving him 60 milligrams of morphine, which is double what we want to give him. And I guess just a side note to that is that tramadol is a weak opioid. He's already on strong opioids. We don't want to, I mean, the dose is too high anyway, but we wouldn't want to go from a strong opioid to a weak opioid when he's having increasing pain uncontrolled on strong opioids in the first place. Okay, I hope that makes sense. But yeah, just pop a message if not. I was wrong. This might be the last SBA, I think. So 56-year-old man, he's got a background of pancreatic malignancy. He's approaching the end of life. GCS is 7, so very low. When you see him on the ward round, his family expressed concerns of significant respiratory secretions, which are seemingly very difficult to clear. And you can also hear them at the bedside. So you can hear this sort of gurgling in his throat. Family are obviously very distressed by this. What medication may be prescribed to relieve his symptoms? And you've got a few different answer options there. And I'm just making a poll. Great. Sorry for rushing you guys. I'm just very mindful of the time, and I'm sure a lot of you are hungry and want your dinner. So basically, the key thing here is recognizing what the issue is. It's kind of in the question stem, but the main issue here is respiratory secretions, which is obviously one of our 4 big things at the end of life, alongside agitation, pain, and nausea and vomiting. So we're worried about his respiratory secretions. The family are worried about it, and we need to give something for it. And I guess the key thing here is obviously the question is asking you what medication may need to be given. And yes, we do tend to usually give something in this scenario or prescribe it as a PRN anyway. It's important to just highlight that I was always taught at med school that actually families get very worried about this because they can hear all these noises at the bedside. And the first time I heard it on the wards, I thought it was very distressing as well. But to patients, actually, most of the time they're asymptomatic and it doesn't really bother them. And it's just a bit difficult at the end of life because their swallow is obviously weaker, so they're not clearing these respiratory secretions as well as a sort of normal person would. So whether or not we treat it with medications is really down to the doctor's decision. But if it's bothering the family, then always worth giving something because it's not going to cause any harm. So most of you have gone for either A or D, either glycopyrronium bromide or hyoscine butyl bromide, which both of them are the correct drugs. But the key thing here is the dosing. So the correct answer here is actually glycopyrronium bromide. And I've been a bit mean here. I feel like I didn't really learn the doses until sort of week before my OSCE. But you may be asked to prescribe all these anticipatory medications for patients in your OSCEs. So worth just knowing one drug and one dose for each of those 4 end-of-life symptoms. So I would just learn that for respiratory secretions, glycopyrronium bromide, 200 micrograms 4 hourly subcutaneous is the dose to give. Oh, and the drug to give as well. Hyoscine is right, but it's the wrong dose here. So the 10 milligrams TDS is usually the dose we give for bowel colic, so Buscopan. And also I've said this patient's GCS is 7, so he's realistically not going to be taking anything orally, and the 10 milligram TDS is an oral dose. And in this scenario, we would give him something subcut, not oral. And if you were to give hyoscine, which is a correct drug, it would be 20 milligrams 4 hourly. So yeah, good. So quick note on syringe drivers. We've only got 2 or 3 slides left. So syringe drivers are, again, something you might be asked to prescribe in your OSCE. And if you do an oncology job or Jerry's job, then it will become a very common part of your sort of day-to-day basis. So syringe drivers are prescribed if patients are unable to take oral meds. And the way we sort of explain to patients why they need one is that a syringe driver will deliver a steady stream of medication through a small plastic tube under the skin. So rather than needing to constantly give them, a 4-hourly tablet or a 4-hourly intramuscular injection, a syringe driver just over a 24-hour period slowly infuses the medication to give a constant background rate of whether it's analgesia or something to get rid of their respiratory secretions or agitation, etc. And I used to remember it as the 4 A's. So stuff to reduce their anxiety, analgesia, anti-secretories, and anti-emetics as well. So things we can put into a syringe driver. Again, I won't go through this for too long, but you sort of know the sort of drugs that we can give. Things to remember is that syringe drivers go under the infusions part of the drug chart. And then I know this might be hard to imagine without a drug chart in front of you, but in the infusion section, in the left-hand side, you've usually got, you usually have to write the name of the fluid. And in that section, you just write made up to 24 mils with either water for injection or sodium chloride, run via subcutaneous infusion 4 hours at a rate of 1 mil per hour. And then on the right-hand side, you'll have the column where you can add all your various different drugs to that water or sodium chloride. And then you'd put whatever, like morphine, hyoscine, cyclizine, whatever. And per syringe driver, you can have a maximum of 4 drugs, but you have to check because some drugs interact with each other. And the BNF is great for this. There's a whole section on prescribing in palliative care, which I would really recommend reading. I think it's super helpful, and you don't need to read all of it, but definitely skimming the sort of important parts. Got a question. Why are syringe drivers not used as much elsewhere? That's a good question. To be honest, I think it's just I think it's a few different things. I think it's a resource problem. So syringe drivers are probably quite expensive. They're difficult to set up. And not everyone needs sort of something to be constantly run over 24 hours. Like in most patients who are admitted to hospital, like, on the gastro ward or whatever, can just have normal meds orally or IV given by the nurses every 4 hours, 6 hourly. And syringe drivers are just for people at the end of life who really can't tolerate any oral meds. And it would be mean, especially if someone's on an end of life pathway for months, it would be mean to constantly be giving them IMs or constantly have a cannula in, which you have to change a cannula every 3 to 4 days. So it's fine if a patient's just come into hospital for a 4-day admission, having some, I don't know, like antibiotics for sepsis. It's fine for them to have a cannula. But if you've got an end of life patient, you don't want to be reciting a cannula, putting needles into them, causing them a lot of pain. So with syringe drivers, you can just put it in once, run things over 24 hours, and you can ensure that they're comfortable with this sort of constant background rate. And I think it's even more important if patients are very unconscious and unable to express their sort of pain or agitation or whatever to you, at least by giving something over constantly as a background over 24 hours, you can make sure that they're, comfortable and not in distress. I hope that answers your question. It's very vague, I know, but it's a really good question. So yeah. And then ethics and law. So I'm not really going to go over ethics and law topics because I think like you guys can definitely go through them in your own time, and maybe we'll try and fit an ethics and law topic talk in if you think it's helpful. But essentially, I've just listed some key things that I think are important for you guys to read up about. So capacity, advanced statements and advanced decisions to refuse treatment, all of your different people who advocate for patients, so LPAs, deputies of court, IMCAs, and then for OSCEs in particular, certifying death and having DNA CPR discussions with patients. So sorry, I don't have time to go through them, but I've listed them here as the things that I think are, definitely important to look through before finals. So just a summary of everything. So we've talked about the main oncological emergencies. Obviously, I think they're all super important, but the key ones to know about are your neutropenic sepsis, because of, you have to act very quick and you have to give them antibiotics in under an hour. And then you, for those emergencies, you do your A to E assessments, and then, just don't forget the key things to sort of treat people with. So tazocin for sepsis, fluids for hypercalcemia, drip and suck for your bowel obstruction, fluids for tumor lysis syndrome, etc. For your specific cancers, it can feel really overwhelming. There's so many of them, especially if you've only got a very short oncology placement like I did. But again, remember your key sort of SBA things, your key tumor markers, know your 2-week wait pathways, especially for like the key cancers like lung cancer, breast cancer, etc. And yeah, don't worry too much about learning. Don't learn the therapies. Don't try and memorize chemotherapies or anything like that. Just know a few of their side effects and toxicities. And then with palliative care, I know we didn't go through it for very long, but key thing to know is those 4 common symptoms at the end of life, how we manage them, and just remembering that at the end of the day, the priority for our end of life palliative patients is making sure they're comfortable with whatever symptoms they may be having. I don't have any references other than just thank you to Sophia, who's my reg, who just looked through all my slides for me. And I've just got the feedback again. Please do fill it out. It's super helpful for us. I'm organizing the medicine lecture series for all these final year lectures that you're having. So we've got a load of talks coming up, but if there's anything additional that you guys feel like you haven't been taught on very much, or you're just a little bit rusty on, then again, just put it in the feedback and we'll do our best to organize any extra talks. The next talk is a surgical one, actually, about upper GI on the 26th of October. And then we've just got our email on there as well if you've got any questions. Dr. Ahmed's just put in the chat, please do mention the quick review resources for medical ethics. I'm so sorry, I have no idea what you're talking about. I don't know if you want to just unmute or just pop in the chat what you're talking about, sorry. But in the meantime, thank you so much, guys, for attending. I'm sorry we ran over. There was a lot to get through, but I hope that helped. And I would love for all the feedback, if possible. And if anyone's got any idea of what the quick review resources for medical ethics is, then feel free to share. And I'll leave the QR code up there. I've sent the QR code in the chat as well, so. So someone's asked, can patients be put on both allopurinol and rasburicase for TLS prevention, given that they have different mechanisms? Great question. No, patients aren't put on, or at least where I'm working on HEMONC, patients aren't put on both allopurinol and rasburicase. It will usually be either or, and our gold standard is usually allopurinol. Rasburicase is only used really if patients have an allergy to allopurinol, which is surprisingly quite common. But the reason why we don't use both together is because they basically counteract each other, I think. And so, yeah, there would be no point of giving them together. We only use one. And allopurinol is commoner. And yeah, feel free to ask any other questions if you've got any, even just generally, if you've got anything. Thank you, guys. Okay, cool. Thank you so much for attending, guys. Like I said, if you're still here, please do fill out the feedback form. It's really helpful for us. And see you at the next talk, hopefully. Bye.